All right, good morning everyone. So my name is Debraj Das. I'm from the University of Alberta and the Mazankowski Alberta Heart Institute. I'm not sure if there's any other Canadians in the audience, but from up north. So I have an interesting case titled A Post-Partum Nightmare. So we have a 32-year-old female. She's G1P1 with no past medical history, no family history. She's only taking prenatal vitamins and she's not a smoker, she's not using any alcohol, and no drug abuse history. She underwent an urgent C-section for obstructive labor, and postpartum day 4 presented to a community hospital with acute chest pain, shortness of breath, nausea, and diaphoresis. On physical exam, she was hypotensive, tachycardic, tachypnic. She's requiring 10 liters of oxygen to maintain her saturations. She has an elevated JVP, a positive S4, and bilateral crackles. So we did a 12-lead ECG at that time, which revealed ST elevation in the anterolateral leads with reciprocal depression. And shortly after that, a chest X-ray, which was reported to have bilateral airspace disease consistent with pulmonary edema. Some basic investigations were also performed. We find that she had a troponin that was elevated, a creatinine kinase elevated. She also had a CT-PE scan, which showed evidence of interstitial pulmonary edema and no evidence of a PE. She had a high white count, she was anemic and thrombocytopenic. So, she was taken immediately to the cath lab. And first shot of the right coronary. It should be looping, unfortunately not. There we go. Nothing too remarkable there. And then when we took a shot of the left system, I bring your attention to the mid-LAD here. Okay, and then we have another shot here. So we use a carrot diagram in Alberta there as a cartoon representation of the coronary tree. And so the interventionalist at the time documented a 90% lesion in the mid-LAD with associated spontaneous coronary artery dissection. So due to her hemodynamic instability, she underwent PCI. It's just the wiring of what we thought was the true lumen. And then we had the insertion of a 2.75 by 28 Zion stent into the mid-LAD. This was the result we got. And then we have one more shot just with the wire out. And again, a cartoon representation of where the stent was implanted. So shortly after that, we had an echo done. EF was documented to be 40 to 45% with anteroapical akinesis and no significant valvular abnormalities. But within 24 hours, her clinical status continued to deteriorate. She had recurrent chest pain, decompensated heart failure, and dynamic ECG changes. She was at a community center, so she was transferred to the Heart Institute we have locally there for consultation from cardiac surgery. Now, before the surgeons wanted to do anything, and due to the fact that she was getting increasingly worse, they asked for another angiogram. And this one, I'll bring your attention to the circumflex territory, the prox LAD, as well as the left main. And this is just within 24 hours. One more shot. And we can see here that from the diagram that there was new dissection, not only in the prox LAD, but now in the entire circumflex territory, as well as into the distal LAD. The right coronary, however, stayed relatively intact. A repeat echo was done shortly after that angiogram. EF had already worsened, was 30 to 35%. There was extensive anteroapical akinesis with only preserved basal function, and there was new mild to moderate mitral insufficiency. She continued to have cardiogenic shock for the days afterwards, decreased LOC, worsening urine output, increasing lactate, and was ultimately taken to the operating room for the insertion of a Levitronics LVAD, and then taken back 72 hours after that for the insertion of a HeartMate 2. She was discharged after 4 weeks in hospital and is currently on our transplant list. So I just wanted to highlight the mechanism for spontaneous coronary artery dissection. It's usually in 4 steps. Of course, you have an intimal tear or bleeding of the vasovisorium, creation of a false lumen, and then pressure-driven expansion of that false lumen, ultimately causing luminal obstruction and myocardial ischemia. This is a nice pictorial representation from the group out in the University of British Columbia. Shows again in the diagram on the right the development of the intramural hematoma, and then ultimately in C, the luminal obstruction and the subsequent myocardial ischemia. Now with, with pregnancy-associated SCAD, the entity is a little bit different. There we have hormonal weakening of the arterial wall and the hemodynamic shifts of pregnancy along with arterial wall stress during Valsalva and labor causing the development of SCAD. Risk factors from the literature are multiparity, in vitro fertilization, and preeclampsia. And oftentimes these patients come in quite a bit sicker. They are often patients who have STEMI, multivessel or left main SCAD, and often have LV dysfunction with EFs less than 40%. And really, revascularization must be considered in all unstable patients. And with that, I'll say thank you.
Thank you, great case. Having seen 2,000 SCAD angiograms last week, is my 2000th.
2000.
I will say, we have a paper coming out in a few weeks showing that the pathology is actually intramural hematoma first, interval dissection second. And what I think happened here is that you seal the exit of the hematoma by stenting. And there was diffuse hematoma at the beginning and just accumulated upstream and spread down into the circumflex. It was a great case highlighting multiple issues. I will say, though, there was TIMI3 flow at baseline, and did you consider just backing off and maybe supporting the LV and not instrumenting the coronaries? That would have been a not crazy thing to think about.
And that was discussed multiple times after the case was done. And the other one was whether or not we needed to use any imaging, IVUS or OCT at the time. But the decision by the interventionalist at that time, because she was unstable with heart failure, was hypotensive, was to insert a stent.
I'm gonna push back on that, just for education purposes.
Of course.
So there were 2 things here. So when we say she was unstable, you have to think about why, because there was TIMI3 flow. And I would urge you and people to recognize that pain in SCAD is often not ischemic. It's coming from the vessel wall. So you have to go on other things. You have to go on the hemodynamics and the flow. And I think that's just an important lesson in SCAD.
Yeah. Would you have used imaging or not? No.
100% no in this case, because the story was so compelling, the angiogram was compelling. There's a paper coming out by a different group in JACC Intervention soon showing a higher risk of instrumentation with OCT. So while it's beautiful images, we almost don't do any OCT these days in SCAD, having done a lot in the early days.
You'll not do your diagnostic test?
I wouldn't do an IVUS for him because you know the diagnosis. Yeah. There's no ambiguity here, so absolutely no reason to do it.
First cardiac cath, very first diagnostic cardiac cath you will do or not?
Oh, yeah. You have to do an angiogram.
Will
miss this.
Is there any experience that this kind of patient, you just give them a sport with a glue pump or impella and then see how they do? Is there anything known that?
Yeah, I actually want to ask about the balloon pump, because there's a theoretical worsening, right, of the dissection with a balloon pump. Would you just put them on ECMO, maybe with an impella and just let it rest? What's your take on that?
Yeah, so the community center that we had didn't have that support. So she was probably in the community center for about 36 hours before transferred. And then it was within, it wasn't really until she was, had worsening lactate, decreased LOC, until the surgeons were like, yeah, we're gonna do something about it. There wasn't a discussion for balloon pump or ECMO right off the bat. We don't have that at that facility.
How about the role of anticoagulation afterwards? Did you keep it going or just do it?
No, we just continued DAPT. We did not continue anticoagulation. There again is, evidence to suggest that the hematoma might get worse with worsening anticoagulation. So at the time, we just continued aspirin, Plavix.
And then once that cycle gets started where you got intramural hematoma, is there any role for a cutting balloon to relieve the pressure?
I think if there's anything at all, it would be balloon fenestration from an interventional standpoint. We could talk about this for hours. It's a wonderful case. We just looked at a whole series of conservatively managed SCAD, and actually 1 in 6 will worsen to the point of occlusion in the first week. So even conservative therapy that I was advocating for is not the ideal scenario. I think the fenestration option is a very reasonable one if there's occlusion. You don't need a cutting balloon. This is an extremely fragile intima. A little balloon at low pressures will fenestrate. And I think if you're going to do anything, that will be my preferred choice of PCI.
Thank you very much.
Can I just quickly ask, out of the 2,000 cases, did you have any postpartum cases?
So there's in the
Freshly
registry now,
yeah.
we have 1,000 in the registry. There's 5% postpartum. It used to be the old literature would say it's 30%. But we're seeing it, I'm sure you're all seeing SCAD these days.
Yeah.
It's now about 5%. Commonest in the first week.
Perfect.
Okay,
Thank you.
Thank you very much.